Research Council in Britain didn't want to spend the money on this intervention unless they knew it actually worked. So they did a randomized trial, actually the first randomized trial ever done in over 1,000 participants. And it showed that that 48% went to absolute zero. So it shows that methods matter. When you use methods to control bias and confounding, what looks like a huge treatment effect turns into a treatment effect of zero. And let's keep that in mind when Dr. Mitchell is going to talk to us about real world evidence and some of the issues with going back to non-randomized evaluations of drugs. So even these large treatment effects can be due to bias. As Reshma said in the beginning of this talk, the FDA regulates products that make up 25% of the US gross domestic product. When you get up in the morning and use toothpaste, deodorant, wash your face with soap, all those cosmetics are actually regulated by FDA. You eat breakfast and the food's regulated by FDA. And then you take your blood pressure medication and that's regulated by FDA too. So I always joke with people that before they barely get out of bed in the morning, they've touched several FDA regulated products. The CDC also estimates that approximately 70% of Americans are prescribed at least one drug. And the top ones are antibiotics, antidepressants, and opioids. That's a pretty sad commentary since the CDC also estimates 50% of antibiotics are given to people who don't need them. Antidepressants may be overused, and opioids, I won't even go into the crisis that we're in the middle of right now. So the CDC also estimates that about half of people have taken a prescription drug in the last 30 days, and up to 23% have 3 or more, and 11% 5 or more. And who do you think those people are? It's more older people who may be more at risk of the adverse events of those drugs as well. So, and who's actually prescribing those things? That would be us, folks, right? We're the ones that are prescribing these drugs to people under the premise that we believe that the evidence shows that those are more beneficial than harmful for patients. And the percent of office visits to a physician where people walk out with a prescription, almost 3/4 of people. So this is a challenge for all of us. What's the FDA's mission statement? The FDA's mission statement that's stated in the Food, Drug, and Cosmetic Act is that the FDA is responsible for protecting the public by assuring the safety, efficacy, and security of human and veterinary drugs, biological products, devices, the food supply, cosmetics, and products that emit radiation. That was the FDA's mission statement from very early days when the Food, Drug, and Cosmetic Act was passed in 1938. But in 1997, a statement was added that FDA is also responsible for helping speed innovations to make medicines more effective. I'm not going to go into that because Dr. Mitchell is going to cover what that means. The FDA also plays a significant role in the nation's food supply and in fostering the development of medical products for naturally emerging public health threats. And we've certainly seen that for the last 2 years as well. So what does FDA do and not do? So the FDA regulates what drug companies can advertise and sell. And in fact, FDA's authority is under the Commerce Act. So the FDA really is regulating what a company can put on the market. It does not regulate what clinicians can prescribe in practice. So if there's been a drug, I always remind people that quinine was used by the Chinese to treat malaria for thousands of years before the US Food and Drug Administration came along. So clinicians are free to prescribe things for which there might be benefit. And also, the FDA does not review products unless a drug sponsor brings it to them to review. So there may be products out there that are efficacious and safe for people, but they've never been reviewed by the FDA. And that gets to the issue that off-label use by us physicians is different from off-label promotion, where a drug company that hasn't gotten the drug approved then goes and tells people that it's safe and effective and tries to sell it. So I think those things often get confused, and the FDA does not tell us as physicians what we can and cannot prescribe. The FDA does make experimental drugs available through the expanded access programs. And this causes a real confusion between approval and access. A drug does not have to get FDA approval for a patient to get access to it through these expanded access pathways. However, the drug company has to agree to let the patient get access to it. And in fact, studies have shown that the group that turns down patients is not the FDA. It's overwhelmingly the regulated industry, which refuses to let patients have access to these things. So it also, the FDA does not approve protocols, approve endpoints, or dictate to sponsors how their studies should be done. And as a person who works in this area of clinical research, I find this is a big area of confusion, that the FDA has to approve how a sponsor is doing a study. In fact, that it would be a great limitation on innovation as well. However, the FDA can put a study on clinical hold if they deem the study unsafe to proceed in patients. So the FDA approves a drug as safe and effective for the conditions of use prescribed in the drug label, not for something else. So even though we as physicians may use it for things that aren't in the drug's label, a company can only sell it for the things that are actually included in that drug's labeling. It includes a specific disease, the population studied, and the dose and duration of how the drug should be given. It's the sponsor's responsibility to determine that the drug is safe for those proposed uses. It is not up to FDA to show the drug doesn't work. In other words, that goes along with the theory of falsification that Karl Popper proposed. A drug is not innocent until proven guilty, and it doesn't work until somebody shows it doesn't. In fact, it's the opposite. Therefore, if a sponsor does a study in, say, young, healthy people, they cannot directly extrapolate that that drug is going to be beneficial for older, sicker people. And those studies need to be done independently, because we as clinicians know that the effects of drugs differ in older, sicker people versus younger, healthier people. So an FDA is not supposed to take cost into account during the review of a new product. And often that's even not known at the time they're reviewing the drug. However, it's very clear that FDA approvals have a subsequent impact on what happens with the cost of those medications. The drug aducanumab for Alzheimer's, or Aduhelm as its trade name, has been in the news for exactly this. FDA approved it on the basis of a laboratory test, and the drug cost an exceedingly large amount of money. And the question was it worth it or not? The other issue is this idea that FDA cannot change anything about a study once it's started, but actually the law says otherwise. It said if a substantial scientific issue comes up to determine the safety or effectiveness of the drug is identified after testing has begun, that the FDA can then ask the sponsor to change the parameters of the study. It's not just a contract written between the FDA and the sponsor. If somebody designs a cure for cancer tomorrow, there would be no reason for people to get on toxic cancer chemotherapy. So in other words, these regulations need to change with the science, and the parameters of the study need to change as the science advances. How is FDA funded? Well, prior to 1992, it was your and my taxes. But after 1992, FDA took in user fees from the regulated industry. And I'm not going to talk much about that because Dr. Mitchell is going to do it next. The major issue with this is that the drug sponsors negotiate what FDA can use that money for. And I always mention that, when I go to get my Division of Motor Vehicles to get my driver's license renewed, or even today, I reviewed my Virginia State medical license. Nobody asked me on the Virginia State Medical Board website how I wanted my money to be used. So this is really very different than how you and I pay licensing fees in our own lives. We don't get to negotiate what that money is used for. How FDA regulations have worked have changed over the years. Prior to 1938, there really was no regulation. The sponsor only had to report they were selling the product. In 1938, the Food, Drug, and Cosmetic Act was passed, and the sponsor only had to show their drug was safe. Actually, it's a problem because you can't show it's safe. Safety means that the drug has benefits that outweigh the harms. And if you're not evaluating the benefit side, you can't tell that it's safe. My own view is this notion hasn't changed. People still look at safety as if it only refers to adverse effects, and it's not. It's a balance of benefit versus adverse effects. And this was recognized in 1962 when the Food, Drug, and Cosmetic Act was amended to say that the sponsor has to show its drug is effective for either in prevention or treatment or diagnosis of the disease under study. Otherwise, you can't tell that it's safe. And there have been a number of other changes that have occurred in the 1980s, and Dr. Mitchell is going to talk about some of these, so I'm going to skip over them. But FDA realized even back in 1938 that if the drug was not working in people, it didn't matter if it only killed one person in a million. On the other hand, if it killed 1 in 1,000, but it was of undisputed therapeutic value, meaning it saved more lives than that, then it could be approved. So the FDA folks have realized from way back, almost 100 years, that safety is a balance of effectiveness versus harm long before 1962, and that it's dependent upon the conditions of use. It's not just that a drug works, it works in whom, when, and on what outcomes. So the interesting history of this is that FDA then published after 1962 regulations that formed what's called substantial evidence from adequate and well-controlled investigations. That is the standard FDA is supposed to use to approve drugs. And I'll show you what those criteria are on the next slide. They put these out in 1970, but again, my field led the way. Upjohn sued FDA over their antibiotic, saying it should remain on the market because of physician testimonials and that they sold a lot of the product. And they took this all the way to the US District Court, and they lost in a 1970 law case called Pharmaceutical Manufacturers of America versus Richardson. And the court also, really importantly, found several things here that are relevant today. First of all, they found that the drug has to have a clinically meaningful effect, not just a statistically significant effect. And I find that very interesting because the drug eteplirsen, when the center director of the Center for Drug Evaluation and Research overrode the reviewers and approved it anyway for boys with muscular dystrophy, that review said that there's nothing in the law that says you have to have a clinically meaningful effect. Unfortunately, this legal precedent says otherwise. The other thing is this notion that, well, if people are really sick and they might die, well, all these rules go by the wayside. Well, the Supreme Court has found the opposite of that as well. In fact, Thurgood Marshall wrote in his opinion, US versus Rutherford. Rutherford was a man that wanted Laetrile for his wife's cancer. Laetrile was subsequently shown in 2 placebo-controlled trials to have no effect and to have toxicity. But Thurgood Marshall wrote, the act makes no express exception for drugs used by the terminally ill, and no implied exemption is necessary to obtain the congressional objectives or to avert an unreasonable reading of the terms safe and effective. Nothing in the legislative history suggests that Congress intended protection only for persons suffering from curable diseases. The rest of this opinion goes on to talk about how these people who are really sick are the most vulnerable of people and actually deserve more protection under the law. The FDA's criteria for adequate and well-controlled investigations has 7 really good, scientifically valid things in it. You need to clearly state what the objectives of the study are, have a quantitative comparison with a control group, which is interesting because so many cancer drugs now are being approved by studies without a control group, to actually have criteria that select the patients with the disease if it's treatment or people at risk of the disease and prevention, some way of making sure that people in the experimental group and the control group are comparable to each other, like randomization, minimizing bias, which I want to point out is right in FDA's own regulations and is a big problem with observational studies being posed for real world evidence. Appropriate methods of assessing the outcomes, and then appropriate methods of statistical analysis. So the courts also found in that another 1970 case, actually that was the same 1970 case, that the criteria must be observed to give the study any chance to yield meaningful results. In other words, those 7 criteria are a bare minimum. So when we talk about regulatory flexibility, there is a level below which the FDA is not empowered to go when it comes to looking at this minimum standard for what the evidence should be able to show. What do we want for our patients and as clinicians? Well, when no therapy exists, we want something that's better than standard of care with acceptable harms, not just better than placebo. We want to be better than what we're already giving patients. And when an effective therapy exists, we want something that's better than what we already have, that's at a reasonable cost. And when we say better, that might be improved effectiveness in treating or preventing the disease, but it could also be fewer or better adverse events, improved convenience, or decreased cost. And unfortunately, decreased cost, most of these interventions actually cost more than the ones that were approved some time ago. And therefore, you have to have one of the above 3 things to make it worth its value in terms of improving patients' lives. One of the big issues is that FDA claims they have no comparative effectiveness standard. In other words, that question that I just posed, that you and I want to know, that it's better, that the new drug is better in some way than the older drugs we already give to patients, they don't have that standard. The only place they do is when effective therapy exists in a life-threatening disease, placebo cannot be used, and also if it's a contagious disease that's life-threatening, and effective therapy exists, they are not supposed to allow drugs that are less effective than those older interventions. The real question comes up is this what FDA is doing? Are they following their own rules when it comes to these considerations that were laid out 25 years ago? One of the big issues that's been in the news, as I said, with the Alzheimer's drug, is what outcomes the FDA is allowing people to use in their clinical studies. FDA and law and regulation spells out that the outcomes used in a trial should either directly or indirectly reflect how patients feel, function, or survive. That means their symptoms of the disease, how it affects their ability to function in their daily lives, or survival. But the FDA can approve an intervention based on what's called a surrogate endpoint, a laboratory test, a physical sign that is reasonably likely to predict benefit. And this is called accelerated approval. The problem with this is now we know what the harms are of the drug, but we don't know whether it really works or not. So it's unclear how one reads into that a drug can then be safe if you don't know if it works, but you know that it's got adverse effects. This is supposed to have a requirement for follow-up studies that laboratory test actually reflects direct patient outcomes on how people feel, function, or survive. And the drug's supposed to be withdrawn if those benefits are not confirmed. Unfortunately, we've seen examples of where that's not happening. And there have been some examples where the laboratory test used actually fails to predict the patient's outcomes, but the drug has remained on the market anyway. Part of this issue is, are the incentives in the right place? If you're a drug sponsor and you get your drug approved, what incentive do you have to do that follow-up study? If the follow-up study confirms the benefit, you've done that study and you don't make any more money. If you do that follow-up study and your drug doesn't improve people's lives, then the drug comes off the market. So the incentives are kind of upside down with this system. And recent studies that show approximately 45% of the outcomes for FDA-approved drugs are based on those kinds of laboratory tests as surrogate endpoints. And the 21st Century Cures Act in 2016 told FDA they should use more of them instead of less. The regulatory standard for safety is more vague, but it's more vague for a reason. It says adequate tests by all methods reasonably applicable to show whether the drug is safe. The reason is it depends what the benefits are. So if you have a drug for nausea, you are not going to tolerate death from that drug because you're not going to die from your nausea. On the flip side, if you have a drug that prevents death, you would tolerate nausea as an adverse effect. So it depends what the benefits are and the conditions of use are, which is why the law and regulation can't be more specific about it. But remember, safe is that balance of benefit versus harm. A drug that does not have efficacy is inherently harmful, even if it just causes you to have a headache and an upset stomach. So what are the recent events that have been going on here? Well, the 21st Century Cures Act passed in 2016, and it was based on a notion that FDA regulation is the cause of delays in getting life-saving therapies to patients. But this really confuses access to experimental agents and approval for marketing. And the other question is, are these notions really correct? The FDA actually approves more drugs than, say, our fellow countries in Europe do. And it also shows that the FDA evidence standards are based on scientifically valid criteria. If you can't meet them, why should your drug be on the market? The other thing is that a GAO report shows that much of this remaining questions have been pushed off to the time after the drug is approved, but there's been very poor post-marketing follow-up on these drugs. As I mentioned earlier, there's now a push for real-world evidence, which in its ugliest form actually means observational studies with no randomization. I published a study a number of years ago where we reanalyzed the Women's Health Initiative study. We analyzed 150,000 patients on over 800 variables and tried to adjust for why the observational studies showed hormone therapy replacement was beneficial and why the randomized trials showed it wasn't. Even after adjusting for 800 variables, we couldn't get the data to line up. So it shows you how no amount of statistical manipulation is going to fix the bias inherent in these observational studies. And what does encourage broader use of surrogate endpoints mean when half of the drugs already use them, as we saw in that previous study? And then finally, it encouraged the 21st Century Cures encouraged patient-focused drug development. Well, what is that if they're encouraging the sponsors to use non-patient-focused outcomes in the clinical research studies? And as Dr. Mitchell will tell you, a lot of cancer drugs are approved on shrinkage of the tumor rather than whether it actually prolongs people's lives or helps them live better. So the other issue is that this is a study from the New England Journal of Medicine showing that over 60% of drugs that FDA approves already get some kind of expedited pathway to speed the drug through the FDA process. So in some regard, you have to ask the question, haven't we already met the speed goal? And should we now be focusing more on quality of evidence? Is this what patients want? Well, not really. A Harvard poll back in 2016, before the passage of 21st century cures, said the public was wary of faster approvals and wanted more government regulation of the pharmaceutical industry. So just to show you these aren't theoretical concerns, here's a list of a half a dozen antibiotics that FDA approved, which actually increased mortality in the patients who received these drugs. And in fact, for bedaquiline, the FDA published an editorial in the New England Journal of Medicine saying that the benefits outweigh the risk for this drug. It's unclear to me what benefits a dead person might actually get. And there was a 5-fold increase in mortality with this drug. That was approved a decade ago. And the follow on a surrogate endpoint, the follow-up study to actually show whether that laboratory test of a negative sputum culture predicts survival for patients still hasn't been completed a decade later. So the challenges we're left with then are these congressional changes in the evidence standards, and the prioritization of speed and access to drugs has resulted in an increased quantity of drug approvals, but the quality of the evidence and the quantity of that evidence is decreasing. The other issue is, I spelled out for you some pretty clear scientific criteria, but is FDA following its own rules on these things? Is regulatory flexibility gone too far? And now we're getting drugs that don't even meet FDA's own legislatively defined minimal criteria. How do we know whether any of this is happening or not? We need increased transparency on what the results of these studies actually show. And the cost of these things really needs to be justified by the evidence. You can't de-link them one from the other. If the evidence doesn't support it, why are we paying the cost for these drugs? So in conclusion, the history of clinical research has evolved over time, and the regulations have as well. And now we have learned that there are inherent biases if you don't have methods of your clinical research that is there to control the biases and confounding. New interventions can be made available through expanded access so patients can get access to these even before they're approved. And this has great implications on the ethics of clinical research as well as clinical practice in terms of exposing patients to harm without the knowledge of benefits. So Reshma, let me turn it back to you at that point. Hopefully we're still on target for time.
Yeah, thanks so much, John. So now that we've heard about the history of the FDA, what FDA is intended to do, we're going to hear a little bit more about FDA's funding mechanism, which is fairly unique. We'll have Dr. Arent Mitchell, who's a medical oncologist and a health services researcher at Memorial Sloan Kettering. He's done really prolific work related to conflict of interest, including some of my favorite studies looking at the role of financial relationships between physicians and the pharmaceutical industry and how it affects prescribing behavior, and has a recent study related to the Prescription Drug User Fee Act, which is must-pass legislation this year that funds FDA's regulatory work related to prescription drugs. Thanks so much, Arent, for being here. Go ahead and take it away.
Running on mute. Thank you. So hopefully we'll cover some ground related to what John alluded to before, related to the funding of FDA. But this is really kind of a summary of a recent paper that I published just out in Journal Medical Care last month. So our question is related to a little bit of the background and history and context of what we know about this, about how FDA is, and I have no disclosures, sorry, about this program called Padufa, which stands for the Prescription Drug User Fee Act. There are now user fee acts for several of the other products that FDA regulates, such as generic drugs, biologics, et cetera. Padufa was the first, prescription drugs being kind of the FDA bread and butter. And this is, as John mentioned, it is the law that changed FDA's budget from being fully funded through congressional appropriations, as a lot of agencies in the federal government are, to getting a proportion of its funding from the regulated industry. Industry submits a new drug for evaluation and approval to the FDA, and they now pay a fee with it. The reason back at in the early 90s was that the FDA was very understaffed. They needed money. Congress wasn't apparently ready to give it to them. So they negotiated with the regulated industry this mechanism as a way to increase their overall budget and their ability to fund and speed drug application reviews, which to that extent, it actually worked. Like reviews got a lot faster and they've remained a lot faster since then. But here's some other context around this Padufa law. They have grown, right? So they started out as user fees started out as a fairly small portion of FDA budget, and they are now approximately 2/3 of the human drug program. Interestingly, it was put into place with a 5-year sundowning clause. And so every 5 years, a new bill has to get written from scratch and then passed by Congress that reauthorizes this whole program. Since that is approximately half of FDA's overall budget at this point, it is, in fact, must pass. The FDA would otherwise have a huge budget shortfall and staffing cuts without this getting approved. And of course, like everything else, Congress does it on a limited time span, basically pulling all-nighters to get this done every time it's due. This legislation is the reauthorization bills are required by statute to be negotiated between FDA and industry. So you can see why FDA might be in a little bit of a bad bargaining position here. They have to have this money. They could get it from Congress, but if Congress isn't going to cough it up, then not getting this bill passed means that they have to cut like half of their friends and colleagues who are down there, on the lower ranks reviewing products, and they don't want to do that. So they need this money. They need to get it passed. And now their money is dependent on the regulated industry. So you can see how they don't have the ability to negotiate for much when they're in part of these negotiations. So we asked in this study, what kinds of policy changes get enacted through Padufa? So Padufa, by which I mean these periodic every 5-year reauthorization bills, they're supposed to be specifically about just reauthorizing the user fee program. But since it's must pass legislation and everyone knows it's going to go through, it tends to attract what people call rider provisions. Everyone gets to, if they want, lobby for and add on these additional provisions that often affect FDA policy, often totally irrelevant things in the United States and the federal government, but often focused on FDA policy that then will get passed as part of this bill. So our question then is, given the poor negotiating position that FDA is in, what is the sum total of these rider provisions? Everything aside from the user fee program itself, what are all of these little add-ons? What is the net effect of these add-ons over time? So this is basically our results table. We read the text of all of these laws, the ones that have happened every 5 years and is due again to be passed this year. We read them all. We filtered out everything that was just reauthorizing the user fees, and then we made a list. And this is basically our paper and our report. A lot of things, most of them, as we concluded, are in the direction that we hypothesized, which is the direction of weaker regulator and stronger industry interest as contained in these provisions. What do I mean by that? We'll just give a few highlights now. First of all, it was contained within a Padufa Reauthorization Act, the second iteration of it in 1997, that changed what the evidentiary standard of the FDA was. In more ancient history, it was actually supposed to be 2 large pivotal clinical trials. FDA had that as the standard. Padufa changed that and said 1 clinical trial is enough. So if you think about things like alpha error, what is the chance that you're going to get a completely ineffective drug approved when you've done 2 entirely separate trials versus just 1? That goes up a lot in addition to whatever other kinds of biases. Prior to this going into effect, the large majority of new drugs actually had 2 trials, 81%. In more recent years, that has now dramatically fallen, and more companies, more and more drugs are taking advantage of this statutory permission to do fewer trials. Padufa, one of the reauthorization bills, mandated what I referred to earlier, which is that all bills in the future, from that point forward, had to be the explicit product of negotiation between FDA and the regulated industry. Yes, there's a lot of other stakeholders there, healthcare professionals, representatives of patient and consumer groups, and industry. But when you look at the number of meetings that actually happen in each Padufa renewal cycle between FDA and industry compared to FDA and all other stakeholders, it is quite stark that the meetings and the negotiations that are happening are really specific to FDA and industry, and everyone else they're kind of giving it's a little bit of a token show to. Many of the different kinds of accelerated and expedited pathways that are now in place were created through Padufa. So the original goal was to speed things, but apparently that wasn't enough, getting review times down to less than a year on average. Now they also needed a lot of these other expedited pathways to get things through even faster, and with generally less evidence review. These have all been part of Padufa bills. And then this one was more recent and really explicit and talks to a lot of the problems that have been in the news recently, which is that by statute, the FDA has been directed through a Padufa reauthorization bill to increase its use of surrogate outcomes. Like it says it right there, use more surrogates, fewer trials with overall survival, fewer trials with clinical endpoints, more surrogates, and with the intent apparently of resulting in fewer and smaller trials. This is what Padufa is telling the FDA to do. It also put in place what we call REMS requirements, which are these post hoc, like after approval safety provisions that get placed on some drugs with safety concerns and high toxicity concerns. And so from one end, you can say, well, they're there to increase safety and monitor the drug for post-approval safety signals. On the other end, it's like, well, the safety programs that go into effect haven't really been proven in any real sense to lessen that degree of toxicity, and that it then allows industry to get drugs that otherwise would not have been approved because we're kind of like treating ourselves. Like REMS I view as the like giving someone magnesium phosphate for like a magnesium of like 1.9, like we do it to make ourselves feel better. And so we've got these REMS requirements that kind of make ourselves feel better. Yeah, the drug will be safe, we'll monitor it, but in reality, you're just getting more toxic drugs onto the market. Looking forward to 2022 in reviewing all of those industry and FDA meetings, the minutes are publicly reported. We don't know the details of it, but certain buzzwords come up with high frequency. We've already mentioned real world evidence. Industry is very big on getting to have their drug labels expanded on the basis of uncontrolled confounding in observational studies rather than effectiveness. They would love to have that happen. Regulatory flexibility and regulatory certainty kind of seem oxymoronic, but what this means, regulatory flexibility is the ability on a case-by-case basis of the FDA to lower its approval standards. Industry would like that. And then regulatory certainty, John mentioned before that the FDA does not mandate the specific design of a clinical trial. But what industry means when they say regulatory certainty is they say like, okay, we're going to do a trial with like this endpoint and this number of patients. Like this is good enough, right? When we do this trial, you will approve the drug. And they want kind of ahead of time certifications from FDA that a given trial design will then lead to approval, making it harder for FDA to change their mind when the results are less than stellar. And then a huge number of increased meetings between FDA and industry. Even beyond the 100 plus that it already is, they would like to see more. And there's a lot of talk of that in the forthcoming Padufa 7. I will end it there and with my contact info, but I will stop sharing and turn it over
so much,
for questions.
Arent. Yeah, thanks so much, Arent. If anyone has any questions, feel free to put them in the chat. We'll address them also at the end if folks want to unmute and speak out. I'm just going to try to paint a picture of hope and opportunity. So bear with me as I share my screen. All right, so folks should be able to see this. So I know we just heard kind of a lot of issues related to FDA regulatory standards, and also how this emphasis on speed, in particular related to approvals, has led to this trade-off in terms of making sure that the treatments that are being approved are actually truly safe and effective. So I'm going to talk a little bit about the opportunity for us as clinicians and also other stakeholders to have an impact, to realign the incentives that we're seeing at the FDA be geared more towards patients and making sure that approved treatments are truly safe and effective. So as was mentioned in the previous talks, we're really at an inflection point because of a lot of the national attention and media attention around the recent approval of the Alzheimer's disease drug called aducanumab, or Aduhelm, that's marketed by Biogen. Some of the issues were brought up in terms of, one, the fact that this drug initially, when it was discussed with its expert advisory group, was being considered for standard approval, was then surprisingly approved due to this accelerated approval pathway based on an unproven surrogate endpoint that doesn't have an association with improved clinical benefit. So right now we have a drug on the market that we have no certainty that actually works and is very costly for patients. On top of that, also serious concerns related to harm, particularly with brain swelling and brain bleeding. And FDA noticed this as a part of their approval, it's still allowing for approval without any sort of sufficient post-marketing surveillance efforts. There's a number of other issues, including the long period of time that the manufacturer was awarded in terms of completing their post-marketing trials to actually confirm clinical benefit, and also to ensure that safety is also being addressed as well, of being 9 years, which is a huge outlier, much longer than other drugs that have been approved through this pathway, among other things. This approval actually led to the resignation of three of the 11 expert advisory group members for this drug or disease class. So that was a huge shock, to the medical community in terms of seeing kind of this overwhelming concern from the scientific and medical community regarding the approval of this drug, and now the continued conversations of what does this mean for innovation of Alzheimer's disease drug. Has FDA set the regulatory standards, so low that any sort of product that has the same mechanism of action can get approval by the FDA, and unfortunately allow for a series of drugs where benefit is unknown and where safety might be an issue onto the market? And is there ways to kind of reset that those incentives for innovation? This is also mentioned before in the talks. There's been a huge emphasis on faster and faster. In fact, the US, compared to other high-income country counterparts in Europe and in Canada, tends to approve drugs much more quickly than our counterparts, and also the increased reliance on these expedited review pathways that have been introduced through the Prescription Drug User Fee Acts over time. Then, Arent also had mentioned this, and John also in this talk. This is just a slide from the Congressional Budget Office that actually shows kind of the overwhelming now dependence of the FDA on industry, and as a result of that, allowing industry to dictate its priorities, really being around speed of approvals and not so much on safety and efficacy. So, that's the problem, but there's some other issues also closer to home in terms of the role of clinicians in the FDA approval process. So there's been a number of studies to actually show that even clinicians who are presenting from the FDA on the behalf of their patients, even through medical professional societies or sitting on independent expert advisory groups, do have significant ties to the pharmaceutical industry that can sway their vote on specific approvals. This has been documented by a number of researchers in the literature, and really it points to the need for an independent counterweight to these medical professional societies and also other groups that are funded by industry that purport to be making statements on behalf of patients and on the behalf of practicing clinicians, but are oftentimes echoing industry talking points and pushing for faster approvals with lower standards for evidence for FDA approval. This year, there's a number of pieces of legislation that are coming down the pike related to the FDA. It's been talked about in the media as the FDA Super Bowl of 2022. Some of it's been discussed here, including the Prescription Drug User Fee Act, which again is a must-pass legislation that occurs every 5 years that funds FDA's operations. But on top of that, there's also the Biosimilars User Fee Act, the Generic Drugs User Fee Act, both of those that have huge implications in terms of access to affordable alternatives to drugs that are on the market, as well as the Medical Device User Fee Act. Again, these provisions oftentimes, as Arent mentioned, have riders on them that lower regulatory standards. And so there have been concerning signs around some of these riders being attached to these bills. On top of that, we have the next iteration of 21st Century Cures called Cures 2.0, where there's financial incentives that are being awarded for certain classes of drugs despite lower evidence for FDA approval, guaranteeing coverage for devices even though they're approved based on limited evidence. And this includes increased reimbursement, which has a huge impact not just on individual patients in terms of their premiums, but on our healthcare system as a whole. Increasing use of real-world evidence despite studies repeatedly showing that real-world evidence, unfortunately, does not replicate the gold standard evidence of clinical trials that we need for FDA approval. And on top of that, for accelerated approval drugs, which, as Dr. Mitchell mentioned in his presentation, have these required confirmatory trials as a condition of their approval, allowing for weaker evidence to be used for those confirmatory trials, including real-world evidence. This includes electronic health records, claims data, things that can be manipulated to show benefit. Other issues that have come up in legislation that's going to be considered this year is issues around representation in clinical trials. One of the most egregious examples we saw of this is actually with the Alzheimer's disease drug, aducanumab or Alzheimer's, where the trials, even though Alzheimer's disease is 2 times as likely in Black patients compared to white patients, and 1.5 times as likely in Latinx patients compared to white patients, actually only enrolled a tiny amount of patients from these marginalized populations. And so this is really concerning given that right now we're seeing it being heavily marketed by the manufacturer to communities of color, but at the same time, not actually running clinical trials in these communities to actually see if the drug's actually effective and safe in these communities. I will say though, we view FDA regulatory evidence or regulatory standards as an issue of health equity writ large. So it's a great first step in terms of looking at representation in clinical trials. But given that our communities of color oftentimes suffer from increased or higher burdens of disease compared to other white populations, and oftentimes are prescribed more medications as a result, the need for improving FDA regulatory standards has a disparate, hopefully positive impact if we can improve it on those communities in addition to everyone. On top of that, there's legislation to help reform the accelerated approval pathway that's being considered in Congress. And so there's a lot of opportunities for clinicians and a need for clinicians to be engaging with legislators and FDA officials to making sure that these bills are aligned with patients and with clinical evidence. So as I mentioned before, this actually builds upon the previous National Physicians Alliance FDA task force that was existing between 2013 and 2019. It was actually unfunded. It was a whole voluntary effort by a number of clinicians from around the country. And during that time, we did a lot of work related to Padufa in its earlier iterations and 21st Century Cures in the form of legislative visits, op-eds, presenting at advisory committee meetings, responding to guidance. And now we have an opportunity to do even more, and with support from Arnold Ventures, to be able to serve as this independent counterweight that's needed at the FDA and also in Congress. So I just want to make sure that folks know that the task force does not require anybody to have any experience with the FDA beforehand. We are going to be inviting expert speakers, including folks like John and Arent and others to come speak to us to be able to give us the information. But I think what's most important is that we have people who share the goal of wanting to ensure a strong and independent FDA that protects patients as being a part of the task force. That's what we care about. This includes, practicing clinicians. All of you have experience in prescribing medications to your patients and seeing the impacts of prescribing these medications on your patients and what this means for them. Also, we work with a number of patient and consumer groups on these issues. And we also very much encourage physicians in training, both medical students and residents, to join us as a part of these efforts. In addition to that, I do mention it's not limited to practicing clinicians. Folks who have had experience or who have interest in these issues are welcome to join us as well. We do ask for a conflict of interest kind of disclosure because we want to make sure that the FDA task force is also an independent body, even with its members in engaging with the agency and with Congress. So there's a number of opportunities for engagement. We have amazing staff support thanks to the funding this year. We also have a Capitol Hill firm that we're working with that's helping us track with FDA guidance, FDA legislation, any communications between legislators and FDA officials around regulatory policy. And with that comes the opportunity to testify before Congress. On February 3rd, I was able to testify before Congress on the Prescription Drug User Fee Act, as well as Biosimilars and Generic Drugs User Fee Acts. And there's a request for actually upcoming hearings to hear from clinicians like you about what you think the FDA should be doing to protect patients. There's also a lot of opportunity to meet with congressional committees. Repeatedly, I've heard from various legislators and their staff these past few weeks that they only have been talking to industry and also patient groups that are often funded by industry. They're not hearing from independent clinicians like yourself. They're not hearing from practicing clinicians who have experience and concern around wanting to make sure that the FDA is strong and independent. On top of that, there's also funding support to attend FDA advisory committee meetings on behalf of DFA. Some of them are also obviously virtual, but we will be able to provide you support in terms of writing your testimony, preparing talking points, and feeling comfortable and empowered to be able to speak on behalf of your patients. And as kind of a little alert, there is an upcoming advisory committee meeting on a new ALS drug or Lou Gehrig's disease drug on March 31st. Also providing public comments to FDA guidance. There's a number of them that are coming down through the pike. FDA guidance is basically how FDA sets regulatory policy, how they carry out what Congress tells them to do through legislation. And there are a lot of opportunities to engage with media, op-eds, meeting with reporters, doing press releases, social media, and so much more. And then finally, probably the most important thing is educating and mobilizing fellow DFA members on FDA issues. I don't know if things have changed more recently, at least, but in my medical training and during residency, I didn't really get any sort of curriculum on the FDA and how drug development or drug approval processes work. Every single time I listen to folks like John and Arent, I learned so much about the agency, and we're hoping to give that sort of education to the broader medical community and to other physicians in training so that we can all be stewards for a strong and independent FDA. So I know I breezed through that very quickly, but I wanted to make sure we had time for questions. So thank you so much for attending tonight, and please feel free to unmute and ask any questions. I know we're out of time.
I think that there's one question that Scott already put in the chat box there that I might be able to address about the vaccines. So
Yes.
Scott, the first thing I would point out is the vaccines aren't approved. The vaccines actually went through something else called an emergency use authorization process, or EUA. The standard for that is, well, your guess is as good as mine. When you actually read the legislation, it says that FDA can use their own judgment to decide what an EUA should be authorized based on. That to me is exactly what President Kennedy said in 1962 shouldn't be the standard for drug approvals. So that's kind of what leaves us in a quandary. And many of these things are being authorized based on studies that were never designed to answer the questions that have been posed. So I think you bring up a really good question, but I wanted to point out that much of what you're seeing during this pandemic has never received FDA approval. It's got authorization through this emergency use pathway.
I will say we do have two vaccines that are fully approved, both the Pfizer BioNTech, right, obviously vaccine, and the Moderna vaccines. And I did put a link in the chat from one of the DFA member and also colleague who's been joining the FDA task force, Ravi Gupta, where they actually looked at kind of the frequency of these vaccine expert advisory committees that were convened during COVID-19 and compared it to historic convenings, or the number of convenings. And it's been really interesting. I will say there are some good lessons learned from COVID-19. The frequency at which FDA did convene these meetings, the amount of information that they put out there regarding the trials has been much more robust compared to other disease areas, I would say, ahead of these meetings. And I think, one of the things that they had made very clear is that they saw this COVID-19 as an important opportunity for increasing transparency, but also trust in the agency. And that's something I'm hoping we can actually replicate, right, for other disease classes. We've actually seen a drop off in the number of advisory committee meetings in recent years for other drug classes and also medical devices. But for COVID-19, there's been an uptick. But this has historically been going down in recent years. And that's very concerning to me, because that means the independent expert advisors that FDA is meant to convene for reviewing these approvals is not happening. And so instead, we're having a lot of closed door conversations between FDA and industry sponsors, and no firewall between the person who's reviewing the applications and making approval decisions and those that are helping industry sponsors with their applications as well. And this is exactly what would happen with the Alzheimer's disease drug. There's a big investigative article that found that there was a lot of unusual collaboration between the agency and industry. And so without that sort of transparency and without, engagement with the public regarding the approval process, I'm worried that trust in the FDA is going down. And so there's an opportunity there for us to propose some reforms. I see Jeff Gordon also has, Jeffrey Gordon. I hope I'm pronouncing your name right. Please feel to unmute and ask a question.
Three quick comments. My vanishing light here of experience. The prior well-known Alzheimer's drug, Aricept, was based on approval on no clinical benefit, but really delaying nursing home admission by 3 months, and yet it became widely approved. I once went to a convention of neuropsychologists and mentioned that I had never prescribed the medicine, and I got a standing ovation from the audience. That wouldn't happen in a medical convention. Secondly, you are looking, I totally agree, and I'm fascinated, actually, I'm nauseated by the presentations, but you have to look at history, and I would just point out the power of Pfizer. Pfizer once almost overthrew the German government because they would not put Lipitor on their formulary, and when NICE in England refused to put Lipitor on the formulary, they got a grassroots patient organization, which they controlled, to create such a ruckus that NICE had to reverse its decision. So don't be humble, but be aware with the opposition. Thank you.
Thank you so much, Jeff. And those are excellent points to make. It can't be understated, the power of the pharmaceutical industry, in these conversations. One of the things that John and I reflected on is that when the NPA FDA task force did exist, we would have the opportunity to meet with Congress maybe once a month or twice a month, but we knew that industry was at Congress's door every day, if not multiple times a day. And with 21st Century Cures, folks might remember there was these big news reports that showed that the Trade Association for the Pharmaceutical Industry hired over 1,000 lobbyists to go to Congress to be able to push forward the legislation. And last I checked, I think there's 3 lobbyists for every single legislator that's been assigned. So, we really do need to have your voice as physicians. The power of the white coat can't be understated. It has been incredibly easy to kind of get time with staff and with legislators in saying that, I'm a practicing clinician and I'm concerned about the FDA because they don't hear these types of viewpoints. They oftentimes hear from essentially like sales reps and lobbyists that are on Capitol Hill most of the time.
Yeah, I thought your slide, Reshma, on medical societies and how much conflict of interest they have, that is the voice that staffers are hearing, that the staffers think represents physicians. So as you pointed out, there needs to be a counterweight. And again, we're not trying to blow smoke at people, right? What we're trying to do is show them the facts.
Any ideas you guys all have in terms of also talking about the FDA to the larger public, right? These things are kind of wonky. They can get really in the weeds very quickly. And so we do want to make sure that when we talk about things related to FDA approval, these pathways are complicated, that we are also able to do this to a wider audience and not just, folks who are studying this or folks, the few folks who might have interest in this. So if any sort of strategies to kind of even talk about this and normalize this amongst physicians would be great, but also the larger public as well. So there's a question. So after we submit our application to the task force, what are the next steps and timeline for getting started? Will you contact us individually? Yes, our first meeting is actually on March 15th in the evening between 7:30 and 8:30 or 7:30 and 8:45. We're going to have a kind of an introductory session and a guest speaker, and then be talking about kind of upcoming opportunities for engagement and working together in becoming that strong counterweight that we're hoping for. So we will be contacting everyone who applies individually, but please do join us. The more the merrier, and obviously the more the stronger. And if you have any friends too, please have them join. That'd be great. All right, one last call for questions. If not, you guys, I think folks have my email from the invite. Feel free to reach out to me. We're going to have the the recording being made available. And if there's any other follow-up questions for the speakers, I'll make sure to also pass those on as well. But thank you so much for joining tonight.